Good evening to all. This is Chandra Mohan, physiotherapist from Dindivanam. A warm welcome to all of you to ExRxIndia.org's webinar Premier League 2020 in association with Sri Samraj Physiotherapy Center, Fitness and Rehab India, YouTube channel, Peak Hill Studio, Sairam Academy. Today's topic is patellofemoral pain in ACL deficit knee. Will be taken by Mohanakrishnan sir. He is working in JIPMER and he is a legend and he is having so much of experience. And I welcome today's volunteer Revati and ExRx team members Dr. Rupesh and Professor Duna Saha. Let us listen to our legend session. Dr. Mohanakrishnan sir.
Yes, good evening.
Please carry on, sir.
Yeah. So first of all, let me clarify. The organizer was kind enough to call me as legend. It's not so. I'm just old enough to be called as legend, but except for experience, I don't have anything in me. So let us all get into the same fray, like we are all sailing in the same boat. So let us start the screen sharing. Let us get into work. This is my usual habit. Before I start, I thank my teachers, my family, my patients, my students, and my good friends. I take this opportunity to thank Chandra Mohan for giving me a wonderful opportunity to speak to you all next time. See, this is going to be the outline of what you're going to experience today. As usual, we'll start with introduction. We'll go on with the mechanical part of ACL and patellofemoral mechanics. And what is there today and what is a possible gap. This is where I just want more interaction to happen. I have my pen and paper. So participants, I would love to contribute for the possible gap. And after identifying the gap, we all will take research suggestions and we'll try to implicate in our routine practice. And we'll take home message finally. Introduction. So today we are going to have a good amount of, I should rather tell you, it's more going to be in detail of ACL deficit in particular, and because of which you can have a lot of altered kinematics happening in subsequent structure, that is your patellofemoral joint, and because of which you will end up with a lot of patellofemoral issues. That is what is going to be our today's talk. Before we could get into the depth of what is actually happening in the patellofemoral joint, let us try to see what is normalcy in that. See, first of all, I would like to always break the jinx. Today we are going to talk about patellofemoral pain in ACL deficit knee. So it is not like patellofemoral pain is found in ACL deficit, or ACL deficit is commonly found in patellofemoral pain syndrome. But to be very clear, ACL deficit and patellofemoral pain syndrome are twins. It is, let it be the etiology, let it be the clinical pathophysiology, or the biomechanics, the pathomechanics, the treatment part of it. Everything is more or less same. So I would rather call it as a twin condition where ACL and patellofemoral pain syndrome are synonymous. This study, what you're seeing on the bottom of the screen by Mayer GD, in the year 2015, he has tried to identify the modifiable and non-modifiable causes for ACL and patellofemoral pain syndrome. The picture on your left, you can see on the right side, left side of yours and the right side of the picture, you can see he has spoken about rear foot varus and the trochlear grooves anatomy. It has got a major say in incidence of ACL injury. And on the modifiable causes, you can see the proximal, the distal, and the intermediate musculoskeletal factors which attributes to ACL injuries. On your right side, you can see the patellofemoral pain, the modifiable cause is exactly the increased knee abduction. We call it as CAM, knee abduction moment. That is the varus going into maximum of abduction, and you can see it in the picture. The varus, whatever the tibia is being subjected to, and because of which the patellofemoral joint is taken for a task. So, students and friends, please make sure which comes first. Nobody knows. But in my experience, with little experience, whatever I have always seen patients coming with severe disability and pain and discomfort and whatnot on earth. They come to me not for the ACL stuff. They come predominantly with the pain in the patellofemoral joint, for which they come and meet a physiotherapist. Under this context, today's paper is going to be online with ACL injury. Let it be the identification, let it be the intervention and the follow. Hope you are with me. So let us see what happens in a normal ACL intact knee. When the knee flexes, there is a measurement what is called as patelloflexion angle. I don't want to get into the depth of it because it's beyond the context of this presentation. The paper in the year 2019, just a year back, this is a wonderful paper which has given in-depth analysis of the patellofemoral kinematics in an ACL intact, ACL deficient and ACL reconstructed knee. Why I'm trying to highlight this paper is it deals in so much that every nook and corner of patellofemoral kinematics is being discussed in detail. For example, as a physiotherapist, we have to be bothered about the patellar height. Patelloflexion angle is nothing but measurement of your patella. Normally, we have the classification of patella aja and patella baja and patella alta. So this is a high range patella or a low range patella. It depends upon the length of the ligamentum patellae and how it articulates. So in a normal knee, it has been measured that the patelloflexion angle is exactly half of that of the knee flexion. And this is very classically noted in the first 60 degrees of flexion. So gentlemen, you should be very clear in understanding this normal anatomy and the physiology concerned with patellofemoral kinematics to that of the knee kinematics. If these two things are happening concurrently, you are unlikely to land up with issues. Now let us get into the ACL deficient condition. Next slide, please. If you see in an ACL deficient knee, the patelloflexion angle is reduced, and because of which there is a reduced translation of the patella in the trochlear groove when the knee is subjected to flexion. So this is what the Linz et al. Have tried to identify the patellofemoral kinematics in relation to the knee movement. What happens actually when knee flexes? The patella has to move, and the patella has to move exactly 50% of the knee, but it doesn't happen in the ACL deficient knee. That is what is happening. So that they have tried to identify and they have documented it beautifully. And I wish all of you should read this paper to understand what really happens in the patellofemoral joint when ACL is deficient. Next slide. Now, the worst part. Everybody thinks ACL reconstruction is the final answer for ACL injuries. It's not so. This paper has dealt in detail, thoroughly. And if you see these three salient features, there is abnormal patellofemoral kinematics. You cannot really say it's in one part. Those two previous slides, they have tried to identify the patelloflexion angle which has altered. The previous slide where ACL deficit, it has found to be reduced. There is a reduced patellar inferior translation. So they have identified in an ACL post-ACL deficit, post-ACL injury. But here in this slide, you see ACL reconstructed knee. There is the first picture, what you see it on your left. Yeah, on your left. There is increased patellar external rotation. In patella, yeah, exactly. Somebody is helping me beautifully. Thank you. Is it Rupesh? Yeah, good. The first picture gives you the patella is subjected to external rotation. So what really happens is there is an altered rotational pattern in patella. And the second point is, that is a middle picture, what you see, there is a lateral tilt of patella. Lateral tilt is best described within this picture I'm not going to get into the depth of the biomechanics. And the third one is called as lateral translation. Actually, when you flex the knee, what happens is the patella glides in the trochlea groove and it smoothly goes in and out. That is the initial part of knee flexion. That is around 60 degrees. But really what happens in ACL reconstructed, there is not only a lateral patellar tilt, but the patella is translated laterally. So that is the combined, I should say, pathomechanics associated to ACL reconstructed. This picture, for the purpose of understanding, I've made it into two, but it really happens. Both are seen synonymous. Like I should say, it happens concomitantly. That is a lateral patellar tilt and translation. It moves out and tilted. Okay, so it is otherwise called as tilted out with external rotation. That is what is the salient feature what they have noticed in ACL reconstructed knees. Next slide, please. Okay, after reading all these three slides, now you have got a rough idea about what happens in the ACL normally, ACL patellofemoral kinematics in an ACL injured deficient knee, and what happens in the ACL reconstructed knee. And out of all these three, the last two, the ACL reconstructed knee has been the worst come scenario. And what is the proof for it? In the year 2013, Osowska et al., they have found that there are two prominent things, and they have marked with MRI. MRI is identified as to be the best gold standard measurement for outcome measurements. So they have tried to identify. I was not able to get the full paper, but despite I was able to get the abstract, it wonderfully says that there are two prominent features in ACL reconstructed knee. That is excessive patellar lateral pressure syndrome. As I previously stated, there is a tilt of the patella. I'm sorry, the slide has moved. Yeah, thank you. The patella has moved. It has moved out and it has tilted out. So that because of which you call it as excessive lateral pressure syndrome. That is called as EPP. That is a syndrome which is commonly treated in Western practice. And there is another thing which is called as patellar lateralization. That is PL. So this paper has completely highlighted the following ACLR procedures. There are two prominent conditions. One is EPP, the other one is the PL, excessive patellar pressure syndrome and patellar lateralization. And you can see this picture on your this. When the forces are evenly distributed on the trochlea groove, the patella just smooth, it glides smooth, and you can see the gap which is being maintained so beautifully. But what happens in a post ACLR? The patella tilts, and there is an excessive stress to the lateral articulating surface of the patella and the trochlea of the femur. Next slide, please. Again, this is a beautiful picture on your slide. The artist has highlighted the effect of light. This was drawn way back. The selfies, mobile, the cameras were invented. You can see the shadow behind. How beautifully it has been depicted. This one picture correlates with this slide for one reason, because again, females are the worst affected. Whatever the condition may be. But as rheumatology, whatever condition, whatever field of science is concerned with, females are the worst, or the most affected. And ACL also has its toll. Yes, ACL more than males. Studies conducted by Sutton et al., they have found that females are more vulnerable because so many reasons. Initially, it was thought like females were vulnerable because of lack of training, but now females have proved that they are nowhere less than guys. They are on par with the opposite sex, and they are doing wonderfully the training part. Now the science have proved that there is a greater Q angle, quadriceps angle, which is attributing to vulnerability. And previously, as I stated, the CAM, that is knee abduction moment, also has a role to play. And of course, they have seen the ACL is a little smaller in size when compared to the male counterparts. And the intercontinental notch, it's a little narrow, which can give little edge to have the rupture of when they have a twisting injury or a cutting, rather, what happens. and increased tibial slope. This is one important factor which has been identified of late, and it's considered to be a very important non-modifiable cause for ACL injury, which is even noticed in males, and it is more increased in case of females, and that is what this study has to say all about. Next slide, please. What really happens? Why we say that it happens more in females, and what happens? What is the real reason? A study conducted by Ireland in the year 2002, they have just tried to make something, but for the first time they came up with a wonderful thing. What happens in landing? I think you people should have seen cat falling from height. Okay, when you throw a cat, it just alters its position. It just flexes the complete body and just lands on the toes, on all the fours, beautifully, absorbing the shock, and the musculoskeletal mechanism comes for rescue, and there is shock being distributed evenly, and there is nothing happens. There's nothing happens to the cat. So what you see on your picture, on your mobiles or whatever you are seeing, on the left-hand side, it is the safety. It is a normal, proper pattern in which you have to land. And the right-hand side of it is that which makes you to get vulnerable for ACL rupture. The picture says it all. I did not talk much about it. But when you have an externally rotated external moment and flexed knee, and with plantar flexion, with a neutral foot, you are less vulnerable for ACL rupture. But in the left-hand side, what you see, you have a forward flexed body. The hip is minimally rotated internally, and it is adducted rather. It should be abducted, it becomes adducted. And the knee takes an extension torque, extension moment, and it predominantly takes the bony stability and not on muscular stability, unlikely to be on the opposite side. And the foot is externally rotated and it is unbalanced, and there is the dorsiflexor activity is predominant, whereas it has to be the plantar flexors. So this paper gives you a wonderful insight what has to be and what should not be, and why females are becoming more vulnerable, and what are the joint biomechanics, pathomechanics which can lead, and what are the muscle works which gives you altered picture altogether. Okay, I just want some answer. Is it a morning or it's an evening in the picture?
It's edited picture, sir.
I know Chandramohan will say, Chandramohan and Vincent will say it's a morning. They are unmarried guys, no? Naturally they say that. Yeah, tell me, how many of you are? It's morning, Ria, Pancha, yeah, it's morning. You can't say it is morning or evening. If you feel fresh and you are woken up from a good Sonia Srivatsava, evening.
Evening, sir.
Evening, why? Priya, early morning. Good. Why do you say early morning? Morning.
For a change, sir.
Yeah, most of them, they have typed it as morning and early morning. See, our present scenario is like what you see, what you feel, and what you deliver. Present physiotherapy status. Present physiotherapy status is what you feel. Our scenario is so bad that somebody feels it in the morning and somebody feels it in the evening. Yeah, let us get into the subject. Sun has not risen completely. Scientific reasoning. Okay, good. Nice to see your answers. Some of them are your awake. Good. What happened to what is the present scenario? It has been found, it has been proved beyond doubt. Next slide, please. A study conducted by North et al., again by MRI study in 2018, they have found that despite you undergo ACL surgery, you have lots and lots of wastings happening in your thigh component and in the foot component. And it may persist for years together, and it has been found in study that it lasts even for 5 to 7 years. That's an astonishing number, but you have to believe it. It has been documented. And despite wonderful physio, unlike all of us, a good physiotherapist, a good proper care, good follow-up, high compliance from the patients, it is not really helping them. Unfortunately, the deficit exists beyond 4 to 5 years, and this is what the sad scenario about ACLR. I think this is a strong message to youngsters, and this is a recent study from 2018. Already I have mentioned ACLRs, the year studied by Lin et al., where they have tried to conclude that ACLR, you have worst patellofemoral kinematics, and this again is a one more proof to give you that ACLR gives you lots and lots of damage in your normal anatomy and physiology. Next slide. What is the good news? Only good news is that quadriceps strength is the key. Whatever you do, whether it is ONE, whether it is synovitis, whether it is X, Y, Z, medial collateral, lateral collateral, posterior cruciate, what X and Y problem you have in knee, finally the rescue comes from quadriceps. And it has been proved beyond doubt, if you have a good quadriceps strength, you have a better cartilage health in your patellofemoral articulation. And as I previously mentioned, when you have excessive lateral pressure syndrome, EPP, and patellar lateralization, you have the lateral patellar articulating surface getting worn out easily. It just brushes the lateral articulating surface, and you can elicit that tenderness easily with your clinical examination. Once you have a good amount of quadriceps strength, and when your vastus medialis is being recruited appropriately on time, and this damage can be limited to a greater extent. And it has been estimated greater than 80% of your quadriceps recovery preserves your lateral articular cartilage, let it be on your trochlea or on your patella. I wish I could have some questions now.
Still no questions, sir.
Yeah, I have a good amount of sports physiotherapists here. I have a question. I know you will not question, so it's my turn to question you all. There is a concept called as agonist and antagonist, right?
Yes, sir.
Quadriceps is called as antagonist or agonist for ACL. Biomechanics. Caroline Krishna.
Agonist, sir.
Quadriceps is?
Agonist.
Agonist for ACL. Huh?
ACL.
Who is that answering?
Rupesh, sir.
Rupesh. Good, 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 good. So Komal Verma, many of them have said agonist. Agonist. Quadriceps and Pavitra. Okay, good, 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 good. Anybody else? I want some fight to happen here. Half of you should say no, half of you should. Vishnu. Who is that Vishnu? Please, please unmute Vishnu. I don't know who is Vishnu. Lakshmi Prabha safe, both. Okay, Vishnu.
Hello, sir.
Yes, Vishnu.
Hello.
You're from Kerala?
Hello.
Vishnu from Kerala?
Yes, Kerala.
Ah,
yes.
Got you. Yeah. Why do you say it is antagonist?
Because during the extension, the tibial anterior translation occurs, so it is on the opposite movement of ACL.
Yeah. Mr. Rupesh is there?
Yes, sir. Yes, sir.
Rupesh, you said it is agonist.
Yes, sir.
Can you explain that?
For translation of knee, that is from tibia to the femoral joint, the translatory force ACL acts. So recruitment of ACL happens. So the anterior part is agonist. So quadriceps is an agonist, and antagonist is its hamstring.
Okay. I think I should have put the question other way. Actually, you have ACL. Today's topic is on ACL rupture. Which muscle is agonist and antagonist to ACL? Quadriceps is
ACL,
agonist.
soleus muscle is agonist, I think so, sir.
Okay. So let me put the answer. Vishnu, that was a good one. Rupesh, thank you for your participation.
Popliteus will act as an agonist. Popliteus.
Okay. Let me put it this way. It is an old concept. It is not a wrong concept. Earlier, when we Rupesh, that was a good one from you, and Vishnu, hats off. Good. Vishnu, you are a postgraduate?
PG students, sir.
Yeah.
Oh, good. You are a specialization in orthopedics?
Musculoskeletal and sports.
Good. I think you are updated with your biomechanics book. Good. See, normally when ACL is being studied, the muscle quadriceps is considered to be an antagonist. Hamstring is considered to be agonist because flexors, that is the hamstrings, they are prime responsible to maintain the tibia in position and preventing it from anterior translation. Quadriceps, other way, it is believed to be causing more anterior translation, and it is considered to be an antagonist to ACL. This is a old school of thought. Enga kaalathula naanga padichadu, like some 10-15 years that was a concept, but now the concept is evolving. I don't say it changes, it is evolving. Okay, Rupesh?
Yes, sir.
You
Yes, sir.
agree
In
with me?
2003, I think so. They have did one study regarding this, sir. The soleus
Excellent.
muscle acts as an agonist.
Excellent.
Yes.
It is not one muscle, Baba. It is the
Yes.
entire limb which works. So you cannot say
Okay.
quadriceps, you cannot say hamstrings, you cannot say soleus, you cannot say tibialis anterior, you cannot say gluteus, you cannot say iliopsoas. It is the entire unit. Any
Okay.
neuro student here? What do you call this unit as? From proximal to distal, what do you call this as? Anybody from the participant? You call it as synergy. This synergic pattern, what really happens is, it has a group, it has a purpose based on one particular activity. You have a motive. No, you want to stand up. Your standing up is your function, your motive. So you extend your hip, knee, and ankle. Yeah, it is synergy from Twinkle Zira. Good. I got good neuro students. Neuro students are brainy. Good. This group of action has a particular distinct motive, and they work synchronously to achieve one movement. So it is a group of action, and that is where the evolution has happened from whether it is quadriceps or whether it is hamstrings. It has called to be a synergistic movement. It is a co-activation, it is a co-contraction rather than it is quadriceps or hamstrings. So both Rupesh and Vishnu are correct. This thought of agonist and antagonist is a little primitive for my age. You guys have evolved, you're young, and you should start getting that synergistic work of co-activation and co-contraction steps. So having said that, thank you for the introduction. Next slide, please. Okay, now, interesting part of the seminar. What are the possible gaps? Anybody? Where do you think we are falling short of? See, whenever you start doing a research, whenever your PG student comes, sir, give me a thesis topic, you just don't say that whatever comes to your mind. You just do a lot of literature review. You see what is the present scenario and what is the possible gap which the student can be picked up and can go ahead and fill in the gap. So what is the possible gap in ACL deficit and patellofemoral pain syndrome, or patellofemoral pain syndrome in ACL deficit knees? What is a possible gap? Next slide, please. Okay, the picture says it all. You have everything, but you don't have anybody to serve. This is a beautiful picture which gives a depiction of a lady who is ready to serve, and she is grieving because she's not able to deliver it. Sad. The therapist situation now is also more or less the same. For one reason, the possible gap is you don't know, you cannot really predict. Lack of prediction, like you don't know whether this patient is going to get patellofemoral pain or not. So without you knowing who will get it, you cannot really go and advise them as a precautionary measure. You wear a mask to avoid infection, droplet infection. But here you are not very sure whether you will be able to, whether you can identify this person, whether he will get into patellofemoral pain, so that I can advise him in exercise and he can stay out of it. So prevention is the best cure. And we lack in-depth analysis. What really happens is, like, no, you don't have in-depth analysis of the possible issues which are concerned with ACL deficits. Not all get it, only few get it. Why? Nobody knows. You cannot say, come on, from here henceforth, patellofemoral pain syndrome has to be managed for all ACL deficit knee. That's a wrong thing. You don't know why. Only certain people have it, certain people don't have it. We don't have that. And the last possible gap is the worst thing what we all of us face. Here, how many participants are there? 26 participants are there? How many?
96. 96, sir.
Oh God, great. This 96 people will have 96 different exercises for patellofemoral pain. Patellofemoral pain is not a very rare and very complex thing. Everybody will have their own knowledge. And with that, they'll have 95 exercises. But if you ask anybody what is a standard exercise, even I don't have the answer. We don't have standardization. We lack standardization. That is the biggest setback to our profession. So these are the possible gaps where patellofemoral pain syndrome in ACL deficit gives you a way for research. Yeah, we'll go to the next slide. Sir, is standard exercise are better or according to individual needs? No, I don't mean that standard exercise, ma. Standardization of exercises. See, suppose you have cold and cough. You need to give a tablet which can take care of both. And this tablet, whatever you give it in Pondicherry, has to be given throughout the world. And that has to work for everybody and not only for Pondicherry people. It has to be tailor-made and it has to be generalized. Is there any exercise of that sort? That is what standardization is all about. Standardization is something like you have a standard norms that gives you a desired outcome for a definite input, for a given input. So how can we standardize protocol for different individuals as pain and conditions are different for everyone? Yeah, I'll answer your question. Who is this? Bilal Qureshi. Okay. I may not be able to remember your name, but just remind me at the end of the session. I'll answer you. Qureshi, yeah, that's a nice name. Okay, research suggestions. See, as far as my little knowledge is concerned in ACL and patellofemoral pain, I have seen these are the lacunas where we don't have adequate study. Perhaps I would have missed it. Just, I would like to highlight a few so that you can take home some of this research questions and suggestions, which you can pass it on to your students, or you can do it for your own. And once you publish this paper, I'll be the happiest person. There are no set of studies which says very relevant to incidence of patellofemoral pain, which basic to the muscle volume, gender specific, based exercise protocol. That is the first point. And the next point is articular cartilage preservation techniques. If some physiotherapist comes up with a paper, says that, sir, I have an exercise protocol which preserves your cartilage, tell me which orthopedic surgeon will not take him for job? He'll be given enough and more of perks and he'll be employed wherever he wants. Let him be India or outside the country. And there are no individualized training methodologies. See, one exercise cannot bring an outcome to you and to me. I definitely will be needing a different exercise protocol altogether than what you require. With age, body weight, race, function, occupation, attitude, sleeping habits, everything can vary. So you have to take all these into account and individualize your exercise protocol depending upon the need what you have. And the last point is CPR. What is CPR? It is clinical prediction rules for footwear modifications. It has been found beyond doubt the excess of tibial rotation because of the foot verum, you have a greater incidence of patellofemoral pain, patellofemoral arthritis. It is once it has been found that excessive of flat foot can be a reason for you to have excess of patellofemoral strain, and because of which you can have a lot of issues. So you need to have some clinical prediction rules which can say that, okay, come on, this patient has got this one, you give a footwear modification, you're definitely going to have outcome. So there is no such CPR for footwear. That's a wonderful suggestion which can be taken home and worked upon. Sir, is it possible and an Asian person different from Europe? Yes, a lot. Who is this? Bilal Qureshi again. Oh, good. Qureshi, if you just see papers, For example, you see patients, what is the incidence of osteoarthritis? In osteoarthritis, one paper say body weight, and this study has been done in Japan. It cannot be correlated to people in Africa and India, in Asia, of course, because the body weight, the race, everything changes from country to country, from place to place. Just consider our country. People are different from India, from north to south and east to west. People from Kerala very strong and immune and things like that. But people from other parts are not as good as and as strong as those people are, for many reasons, many reasons. So you cannot really say that this population. So you have to do for your population, find out what is the exact problem and find solutions for it. I think I've answered. The next slide, please. Okay, taking from this research suggestion, today's paper, we need to have some clinical implications. Yeah, you need to get some fruits, put it in your basket, and take home and deliver it to your family. Family is your patients, so you need to have something take-home message. Next slide, please. This wonderful personality I admire a lot. The person whom you see on screen, Stephanie D. Stacy, a wonderful physiotherapist, happens to be a co-editor of Joe's PD, wonderful physiotherapy journal. And her research interest is in three-dimensional motion analysis, and she's the top person for putting a paper in neuromuscular strategies and exercises, things like that. And the people who are in SRM will be very much acquainted, because most often I take her name. Thank God she doesn't know me. So I have been taking her name quite often, and many papers have been published on her name. Next slide, please. This paper is worth reading, Believe me, I have read it some 10, 15 times, but still if you ask me something, I'll not be able to answer you properly, because it's so much in store. And what this paper really talks about, it talks about the neuromuscular components. What components of neuromuscular? When Vishnu and Rupesh were discussing about the agonist and antagonist, the thought, which was way back 20 years, was cause for, or it has to be analyzed. No, you should not strengthen the quadriceps. You should strengthen only the hamstring. They are the agonist, quadriceps and antagonist. So don't work on quadriceps. Those thoughts evolved, and we are in a state where we have to work on a synergistic pattern. And that synergy comes from a neuromuscular domain. And this paper has attributed the risk factors, the predominant neuromuscular deficits, which can give rise to ACL injury, the incidence of ACL injury. And they have tried to highlight what happens after the ACL injury. You take a person, you see that these are all the neuromuscular causes which can give rise to ACL injury. And this paper again deals in depth what all the neuromuscular deficit in ACL injured patient might develop. And as any paper discusses, what happens to the neuromuscular strategies after ACL reconstruction. And it is not enough that you identify what really happens in the body and the neuromuscular strategies, but you need to also know how to evaluate. And after evaluation, you need to intervene. The best part, and I should say the feather in the cap, is that they have managed to assess this neuromuscular deficit. And after the evaluation, they have tried to intervene with exercises. Believe me, it's just exercise, and exercise. Nothing more than that. No taping, no pinning, no stapling, nothing. They have just managed to do with exercises. And this paper beautifully speaks about symmetry. So far, I'm not sure whether you have been following up this the slides, but believe me, guys, students, friends, this particular slide, this paper, just download it. It's freely available in Joe's PT. Full article is downloadable with exercises. So normally we have an habit. No, I have something. I always keep it with me so that nobody is going to look at it and learn from me. No, I should not show it. This person has displayed it through the world, the neuromuscular strategies with which how you can work it. It's a wonderful paper. He has given some 8, 9, 10 pages of exercises alone, how you progress and how you work on that. I'm not going to get into the depth of the paper, how it deals with, what it deals with, what all the exercise has to be done beyond the scope of yeah, thank you, Pooja. Yeah, beyond the scope of this presentation. But I would love you guys reading this paper once in your lifetime. I can bet you have to read at least 10 to 20, 15 times for you to understand little. Maybe my brain has gone old. You youngsters, if you read it 10 times, I think you'll get a better picture. And everybody should definitely go through this paper. Okay, why I'm talking so much about this paper? Next slide, please. Yeah, this slide speaks volumes. I was talking about the neuromuscular impairments pre-injury. That is another, that's otherwise called as the risk factors which can predispose an individual for a ACL rupture. In the first block, the top one, what you see, excuse me. Sorry. The first block, what you see on top, it's called as low hamstrings and quadriceps ratio. I think I don't want to get into the depth of it. And increased external cam, which I already spoke, that knee abduction moment, and deficit in trunk proprioception and increased trunk displacement. These 4 factors are found to be the key risk factors, which is of neuromuscular in origin, neuromuscular impairment, which can predispose an individual to an ACL injury. And the second block is called as post-injury neuromuscular impairment. They have seen a marked quadriceps weakness, which is related to effusion and effusion. Knee instability because of ACL discontinuity. Dysfunction is there, so naturally you'll have an instability. And there is a restricted knee movement. I would rather say, friends, a restricted knee movement in post-ACL injury or post-ACLR is one definite cause for all the troubles to be invited. Let it be extension or flexion. I would rather go more with extension. Extension is the most important function of the knee. I don't really mind about flexion because flexion happens by itself and flexion is not so functional, believe me. Extension is very, very important, very, very important, especially when you are going to talk about patellofemoral articulation and pain issues are concerned. Extension restriction is the key factor. Extension is the key factor to be identified, evaluated, attended, and treated properly on time. That's very, very important. That's in post-ACLR, post-injury and as well as reconstruction. And the third one, what you see on the second block is a restricted knee movement, very important. And the fourth one is going to be the kinematic and the kinetic asymmetries. What happens? Why you call it as asymmetry? Asymmetry and symmetry. Why do you always talk about that? Can we just go to the previous slide, please? Previous slide, I'm sorry. Previous slide. Yeah. What is the last point you see? That is the symmetry. What does symmetry means? Equal. Symmetry is very, very important. You don't understand anything in ACL rehabilitation. There is nothing big here. ACL rehabilitation is very simple. What is the important take-home message? What you should have in ACL reconstruction knee or ACL injury or whatever, even if it is OA, forget about it. Symmetralization. That is the important highlight. What Stephanie D'Stacy often gives a push to symmetralization. Symmetry is very, very important. Next slide. From here, I would like to take the importance of kinematic and kinetic asymmetries of knee and hip. You have an injury on the right side. Left side is normal, but left being normal itself can cause a lot of problem to the knee on the same side and to the affected knee. Let me not get into the depth of it. This asymmetry of both the proximal and the knee, that is the proximal hip and the knee, and sometimes in the ankle also it can cause. So the joint proximal, the joint distal, asymmetries can cause lots and lots of trouble, both to the opposite side and to the same side. That can lead to a lot of issues. And you see the last box. This is what the worst come scenario. You see it in very common ACL reconstructed knee. They are found to be present in post ACL reconstructed knee, and this itself, they say, is a risk factor for a second ACL injury. The second ACL injury, what you see it on the right side, yeah, CAM, tibia puncture. CAM is knee abduction moment. You see a girl jumping from top, you know, when she jumps, when she lands, you can see the knee, both the knee touching each other. That is because of the proximal stabilization is lacking enough. That makes them more prone for ACL injury. That is what a CAM is all about. Okay. So the last box is the net hip internal rotator moment, increased knee valgus motion. Again, that is the CAM. Asymmetrical external knee moment, like when you don't have adequate knee mobility, and reduced postural stability can give rise to second ACL injury. Why should we talk about ACL injury, the neuromuscular strategies, the risk factors, after deficit, after injury, after deficit and after ACL reconstruction? This all can have an equal say in patellofemoral arthritis. When you have a quadriceps weakness, invariably you'll end up with altered bipatellar kinematics, which can lead you to patellofemoral. So it is inevitable for me to avoid ACL and talk about patellofemoral. When you talk about patellofemoral, you have to address ACL, ACL neuromuscular impairments, concern with ACL, which also addresses the patellofemoral structures. Next slide. Do we have any questions for this slide? Can we go to the previous slide, please? Do we have any questions? I would love to answer.
No questions, sir.
So I'm sure everybody has slept. Good.
No, sir. No, sir.
Anyway, next slide. Next slide. Yeah, taping. Taping. See, I'm not a very keen campaigner of taping because I don't do it. I don't do it, so I should not talk anything about it. Only thing I can talk about what I do it. So this is the only thing what I do. I do rigid taping on a normal basis. Taping does help. It really works wonders, especially when you are rehabilitating an ACL injured patient, where he's refusing to do a specific exercise patella because patella is moving too much away. What you call it as patella lateralization is happening on the patella, and patella taping comes very handy. No, it is very, very cost effective. It can be done on the table. What you need is, you just need a tape just to tape an asked exercise and remove and send around. So this paper, which was published in, I think it was published in year 2000 or way back, yeah, 2017, the latest paper, and it is clearly, very clearly, and this paper is a systematic review. Ladies and gentlemen, please make a note. This is not just a RCT or just a review article. It's a systematic review, and they have studied so many articles, and they have said, yes, taping does help, but it is not just taping alone which helps. Taping with exercise, it's an adjunct. It is not the primary means of treatment of patellofemoral. Exercise are the main means of treatment. Taping will help you along with exercise. That is what meconal taping is all about. I know there are some controversies now regarding meconal. I don't want to get into the controversies, but in my experience, I have seen taping really works. Whether it is placebo or it does have an effect, I'm not sure about it, but it really helps. Next slide, please. Okay, we have some good news finally. There is, I was talking about clinical prediction rules. So clinical prediction rules can be for evaluation, for deciding a treatment, and for you say like, no, you give a paracetamol, the pain will come down definitely 60%. So you can say the effect of the intervention, whether it will work out or not. So this is what prediction is about. Clinical prediction rules are all about. It's very important for a postgraduate to know, and for clinicians as well. So for taping, taping work to whom taping can be of use, they have found two important factors. One is tibial varum if it is more than 5 degrees, And if the positive patellar tilt test is positive, then there is a positive patellar tilt test, I'm sorry, then this patient will be more benefited with taping. They have found, that is Lesher et al. They have found this, and this article is in Joe's PT, that is also downloadable, and it's a good one. You just see, and I just would love in this 96 people, some 2-3 people come up with some good CPR and PFPS in future, maybe after some 25 years, I would be happiest person. So just guys get into business and just find out some way or other, some CPR or something, which you should have seen of late. Now get into one domain and just start working on that domain, and you will find wonders happening. Believe me, these things were not done in one day. Next slide, please. I think I have a question. Yes. Listening.
Not a question.
Nowadays taping become cosmetics, sir. Yeah, they have colorful. I have seen mehendi taping and all. It's really good, yeah. It really makes wonders. Yeah, good. Okay, this patellofemoral pain syndrome, how do you quantify it? Okay, you have an X-ray, you have an MRI, you have CT scan, you have that, you have this. But on paper, how do you do it? From the physiotherapist point of view, this Kujala anterior knee pain scale, a funny name, but it really is a good quantification of your knee. It's a patient-reported outcome measure, which has got some 13 questions, and it is available. Some of the people know they are tired of calculating. I'm not good in math, so I want a website which gives me. Yeah, there you are. Orthotoolkit.com gives you a way where you can answer all these questions, which give you a quantification of what is all about, and you have the score. The score will definitely give you the quantification, how severe you are, and this can be measured on a periodic scale, whether you are improving or not. That's a what tool, and it's valid and reliable, and it has been translated in so many versions. I would rather say, yeah, Kujala is a very good scale for a PFPS, whether it is ACL or ACL deficit, or it is a normal one. Next slide, please. So I think I'm catching up the time. I'm concluding the session. This picture, what you see on your screen, a lady standing on a leaf. Leaf where? On the lotus leaf, which is floating on the surface of the water. What an imagination the artist has. What a beautiful breeze, and the lady is experiencing it. And can you see the one knee is flexed, the other one is flexed, the other one is extended, and the flexed knee is not on the leaf. And the leaf, and you can see that she's standing on the center of the leaf. I would rather see it as the wobble board exercise. And the unstable base, the demand what the individual is being subjected to, can have a neuromuscular stimulation. And the lady is standing so comfortably without, I know this is imagination, but despite, a therapist should have this outlook. The neuromuscular strategies, which is highly individualized, would be the best intervention for patellofemoral pain with a concomitant ACL deficit knee. I would rather say any exercise which is based on neuromuscular strategies, which is highly individualized, will be the best solution. And I would rather say that should be the take-home message for you all. Next slide, please. Yeah, this is not about physiotherapy. I just want you people to see the bottom. You see a stamp there? The India stamp and wonderful artwork of this person. He's none other than Raja Ravi Verma from God's own country, a very small village from near to Trivandrum. He's a royal, he's from a royal monarchy, but he has made wonderful arts in that time where you don't have even a photograph being done. You don't have models for you to pose. He has made pictures. The pictures what you all saw in every slide belongs to this person. He is such a wonderful artist, and he has managed to mix up the fusion of Western and Indian culture. He has not left, you can just go through all the paintings, he has not left any Indian, he's not the bindi or the kajal or the hair. He has tried to mix up beautifully, and he didn't have any demand, no? He was a monarch. No, he's like king. You know? So he need not have any force to go and sit and paint. He had a passion. He has a passion towards art. That was which it pushed him to this part. And in government of India had given a stamp. Nowadays nobody is using a stamp. In those days, getting a stamp, no, it's considered to be the highest prestige of everybody has been given a stamp. So nowadays, stamp is no more, doesn't exist. And you know how much of struggle he should have undergone that time. And he was not really, it was not a need for him to make a painting for his living, but he did it. He did it. Even now today, he's not at all concerned with physiotherapy, but we speak about Raja Ravi Verma because of his masterpiece. And I wish every physiotherapist should have a passion towards their own domain. They just should get into the depth of it. Work for a long time, consistently. You will have hardships. I know it's not a cakewalk. Everybody has got trouble from home, from office, from road, from society, from country, everywhere. But you should fight it out. Fight all the odds. If you want to flourish, you really have to flourish your profession. You have to work hard, prove. And we are in science, no? This is science. You have to prove it to the society. Like Raja Ravi Verma, I wish all these youngsters to come up with flourishing colors. And the best way to be noted, the next slide, please. The last one, I promise. The way to get noticed is to a quality work and not a quantity. Quantity never speaks. The quantity is in your pocket, the quality is in your heart. Always work from your heart, be creative, live up to your passion. And I wish all to become like Raja Ravi Verma. And God bless you. Thank you. Now I think it's for time for questions.
Yes, thank you so much, sir, for the Raja Ravi Verma's class. Sorry, patellofemoral pain in ACL deficit knee. We can take questions from participants, sir.
Yeah, I think it's better they question me directly rather than typing. Typing, you know, takes time.
Yes, participants can unmute yourself. Any questions?
I would like to first I'd like to get a question from Rupesh sir. Yes, Rupesh sir. I'm here for you. Yeah, I'll answer you, Supraja Veeraraghavan. First I'll answer Rupesh question. Yes, Rupesh.
Nothing, sir. I usually get cases of patellofemoral pain syndrome in the fast bowlers and spinners. So when their landing is different, that is when there is lack of ankle mobility, we get these issues common, sir.
Excellent.
So
excellent.
I have been suggested for their arch, that is foot arch has been modified, and then the proper activation exercise on quadriceps and the ankle mobility exercise help the most, sir.
Okay, Rupesh sir, I'm making a note of this. Good. Yes, and I would love that you measure all your your players' foot morphology and their mobility. Based on this, maybe we can come up with some good papers.
Yes, sir.
And we can take Chandra Mohan's name also there.
Sure, sir.
Yes, sir. Yes, sir.
I would love to hear from you with enough and more of documented thing from your players. So you have good players with you, so you can measure their foot morphology and you can help us in writing a paper.
Definitely, sir. I have recorded of it also, sir.
Thank you, Rupesh, sir. Yeah, there was one question from, who was that? Yeah, I think you can read out the questions or whatever.
Yeah, sure, sir. Thank you for the opportunity, sir. Yeah. Hi, sir. I'm pleasure to be here.
Yeah.
And actually, in Bharatanatyam dance, we do follow that unbalanced position, as you said, sir. So throughout the dance, we used to follow that position. And there, I have read in an article that there is a chance of patellofemoral pain as well as other knee joint disorders, sir. So is there any particular exercise to prevent or reduce the chance, sir?
Are you a Bharatanatyam dancer?
Yes, sir, I am.
Which stage did you learn up to?
I'm learning for 8 years, sir. 8 to 9 years I'm learning, sir. Illa, sir. No, not yet.
Okay. See, in Bharatanatyam, you have got various phases, ma'am.
Yes, sir.
There is one stage which is called as Aramandi. Okay.
Yeah,
that is
yes,
the first
Aramandi.
stage. Yeah, that is what the first stage. It is something like a half squat. You have to put your hands on your hips and you have to stand with an externally rotated hip with the heel touching each other, and you have to externally rotate to the extent that you are almost in the coronal plane.
Yes.
Okay.
Yes.
So
yes,
in that
sir.
position, you have to stand and train for yourself. So unless and otherwise you have this basic norms, mudra and solvaanga. அதுக்கு ஒரு ஸ்லோகமே இருக்கு, பரதநாட்டியத்துல ஒரு ஸ்லோகமே இருக்கு. அந்த ஸ்லோகத்துல பாத்தீங்கன்னா முத்ரா வந்து இஸ் வெரி இம்பார்ட்டன்ட். இந்த முத்ரா வந்து இட் இஸ் த டெபிக்ஷன் ஆஃப் த ஹோல் பாடி. ஸோ இந்த அரமண்டி அப்படிங்கிறது இட்ஸ் அ வெரி ஸ்பெசிபிக் எக்ஸசைஸ் விச் ஹஸ் பின் டிசைன்ட் டு இம்ப்ரூவ் யுவர் knee strength, especially to avoid patellofemoral pain syndrome. Okay. So it has been time and again it has been proved aramandi practice பண்ணிட்டு பரதநாட்டியம் ஆடினா patellofemoral pain வராது. திடுதிப்புன்னு ஆர்வ கோளாறுல இறங்கி நிறைய ஆடினாலோ இல்ல அளவுக்கு மீறி ஆடினாலோ you are vulnerable for patellofemoral.
Okay.
That is what my knowledge is about, because my daughter was a Bharatanatyam dancer. I'm talking this, so don't mistake me. So it is lack of practice or deconditioning can attribute patellofemoral pain syndrome. If you practice it regularly or if you exercise regularly, you are unlikely to have patellofemoral pain syndrome, because Bharatanatyam is a wonderful art. It will never give you pain.
Yes, sir. Thank you so much for the information. Thank you, sir.
Yeah. Anybody else? Any questions?
One more question is from Aishwarya, sir.
Yeah.
She had a football patient with sudden patella dislocating superiorly. What can we recommend immediately on field, sir?
See, actually, this is Aishwarya to everyone. Yeah. Okay, Aishwarya, I think this is more of an acute management on the field. I think Rupesh will be a better person to talk about than me, because I'm an old guy sitting in the department. He is a young guy who was running behind a patient, and he is the one who will manage on the field. And let us see what Rupesh sir says.
Sir, you are putting me in trouble, sir.
Arey yaar, treating is trouble.
No, answering is trouble, sir. Sir, immediately we'll remove him off the field, sir, because it is in acute condition. We'll remove him out of the field and then we'll treat and only we'll send him, sir.
Yeah. Actually, patella getting dislocated superiorly is a rare phenomenon. Patella normally dislocates laterally or medially, and it is very common in females. And it is much more common in females where they are lax. They call it as hypermobile. Last week, we were hearing to Kamlesh. You have a scale now which measures all the 7 points, and if the 7 points are 5 or 4, more than 4, you are vulnerable for all dislocations. Especially patella is a very vulnerable joint. So superior dislocation is very uncommon. You normally take him out and put some ice and send him to an orthopedician. It's not our job. Once it dislocates, it is up to him to manage and recuperate. Once he comes back after recovery, it is up to a therapist to rehabilitate, strengthen, condition, and put him back to the field. And that's where Rupesh comes. And I come inside the hospital and Rupesh comes on the field. So that's where our role to play. But I think on the field, it is much about an acute management where you try to splint him and put him out of the field and take him to the hospital and treat him. Hope I answered your question.
Next question, Rupesh.
Yes, sir. From Dr. Bhushan. Sir, in rifle shooter, have seen PFS in right knee and all have low arch in foot. What specific exercises, sir, can you suggest?
See, I would rather say, I think he's a physiotherapist, right?
Yes, sir.
Yes, sir.
Yes. I think, sorry?
He works with the shooting team.
Oh, good. Sir, actually, I think you have to work on a neuromuscular framework rather than just on one specific muscle group. As I was mentioning, if you just go through that Stephanie D. Stacy article, it just gives a very, very elaborate outline. And if you see the neuromuscular strategies or the neuromuscular impairments, what she has stated, and the particular person, you can also screen the same way what she has done. And if you could elicit the same findings, what Stephanie has seen, and exercises what she has prescribed in her paper, would be a suitable one. I cannot just like that say that this exercise, that exercise, that would be a wrong thing. Rather than that, you have to evaluate thoroughly the proximal and the distal components, the trunk stability, the individual's motor skills, and it has to be incorporated accordingly. It has to be individualized, sir. I don't think we can definitely say strengthen the tibialis anterior or tibialis posterior would be a wrong answer. It needs the careful evaluation. Hope I answered him.
Barney, please.
Hi, sir. Good evening. I'm Barney Cordova from the Philippines, and it's my pleasure to be in here.
From Philippines. Oh, good. Yeah.
Hi. So I've always been using proprioception on my clients with ACL, but being on a practice here in the Philippines, I come about 1 out of 5 with ACL injury. I live in a small town, and I'm just curious if how does proprioception I consider proprioception as part of neuromuscular activity, right? As a neuromuscular predictor. Do you consider it?
No, your question is proprioception affected in ACL injury or not, right?
Yeah, and for PFP as well.
PFPS, yeah. See, in PFPS, you are very sure that there is a neuromuscular impairment. It can be mechanical or it can be physiological. If it is mechanical, it is mostly associated with a flat foot or with increased Q angle, or you have hypermobility in that individual. You can have this mechanical cause attributing to patellofemoral pain syndrome. But I rather strongly feel if there is any preceding injury, suppose the individual should have had around the back, around the thigh, around the foot, or anywhere, even it can be a mild strain to the great toe, can cause an altered neuromuscular activation, because of which you can have an altered mechanism altogether. So this can attribute to patellofemoral pain syndrome. So I just feel that neuromuscular impairment does exist, and it has a preceding incident of injury. It can be a minor injury to a major injury, or the individual should have had a major injury in which he is recuperating from. And I just have a feel that those individuals whom you are attending to, I think they have an acute injury rather than a chronic injury. Am I right, Cordova? If I'm spelling your name right?
Yeah, I think you're right about that.
Yeah, I think you're witnessing more of an acute stuff, na? Like a day before, the day 3. But I'm talking more about a ruptured, not just an injured. Okay, it is more of a ruptured, where is a mechanical discontinuity, where they had an immobilization being done, followed by which they have started to have symptoms of patellofemoral pain syndrome. So I would rather attribute it to the chronicity of the condition, not just you may not witness PFPS in acute state where they had injury a day or back or a week back.
Okay, got it. So you're suggesting that I can improve the mechanical.
Yeah, you have to identify the mechanical deficits. You have to have a Baton score being done to those individuals, and screen them thoroughly, and have a movement analysis done either by camera or by yourself, and that can answer your question.
Okay, thank you. And by the way, I appreciate the orthotoolkit.com. I just browsed it, and the website that you suggested, I haven't gotten in it, and I browsed it, and it's a good website. Thank you about that, and thank you for your answer, doctor.
Oh, thank you. You're welcome.
There is one more question. Please read it out.
From Sharma, sir. Many of the housewives suffer from PFS. Sir, can you suggest some exercise, please?
Good. Neham, see, most of the housewives will have it. Naturally, okay, it's a network issue. Good. Nice excuse. Okay. See, normally a lady will have. You take a guy and a lady will have. Lady inevitably has. And throughout the presentation, I was attributing to CAM. I was attributing to hormonal stuffs, hypomobility, all these stuffs will definitely, they are more prone for it. And if you ask me any specific exercise, I would not say quadriceps exercise. I would not say back exercise. I would rather say fitness, okay, general fitness for housewives. See, I'm telling you, my wife is stronger than me. All wives are stronger than the husband. That is a different story altogether. But definitely a wife at home is stronger than the husband for one reason. She works both in the office and at home, and she does all the household chores. She cleans, she washes, she cooks, she dries the clothes. See, all this work will definitely give her an extra edge more than the males. Okay. So what I would rather say is, no, you can or you might see this particular patellofemoral pain in housewife. There can be two possibilities. One can be because they are working in excess. Even though they are strong, they may work little in excess, because of which they can have patellofemoral pain. And patellofemoral pain alone is not the problem. They may have associated low back pain, or they may have associated foot or any other symptoms along with this. And there can be another instance also. They will not work at all. They are in the office, they are sitting job, desktop work. So all the time they are working in front of the computer. At home, you have the husband to work, you have the maid to work. Those sort of instances are there. So these two extreme characters, you have got a different role to play. The first example, you have to contain them, you have to protect them, and you have to modulate their work. And the second example, you have to make them work. Because this pain is caused because of lack of activity, lack of mobility, and lack of strength. So this second group needs intervention. So I think you have to make an evaluation on the socio, psychological, and physical aspect of it, and analyze and then intervene. It is not that I should say quadriceps exercise. Okay, believe me, housewives are strongest. Okay, so you have to really see what is the cause for the pain and attend it appropriately. And that's why I say you cannot generalize exercise. You have to individualize. So for which you need to have a good amount of evaluation being done. And for this case, you have to have a good psychological status thorough evaluation being done. And based on this, you have to give a prescription. Neha Sharma, have I answered your question? Okay, I think Neha got it or should have got it. So it has to be individualized, so you cannot really say this exercise works. But one thing, a good amount of quadriceps strength and good fitness will definitely help. Okay, thank you. She got it. Any other questions?
How to reduce the prepatellar swelling?
How to reduce prepatellar swelling? See, prepatellar swelling, you can have any irritation to the synovium, which can be of acute in nature. So a physiotherapist role will be mostly to contain the issue. Either you can go for ice packs application and a compression bandage of sort. And I don't think you have to intervene. I think you have to stay away from synovitis state. At the most, you can go for isometric quadriceps exercise, and you have to contain him, unload him, partially unload him, and protect him. From Kajal Patel, sir, you can again explicitly explain on cam. Yeah, cam. Okay, good. Okay. What is her name? Pooja. What is her name? Kajal. Okay, Kajal. Have you ever jumped? Okay, Kajal. When I ask Rupesh and Kajal to jump from height, not very high, at least from a chair. When you jump, at the time of landing, what really happens when Rupesh jumps? When he's landing on the toes, what happens? No, his knee and hip, they are in alignment. What happens is the hip is externally rotated, the knee is partially flexed, and it is a neutral, and it is almost parallel to the other foot. You got it? That's how Rupesh jumps, because he's a sportsman, he's fit, he's a guy. What happens to a girl who doesn't have a practice, who is not good in sports, who is little on the heavier side, who have never jumped? If you ask her to jump, at the time of landing, what happens now? Her complete foot comes in contact with the ground. The knee, both the knee comes in contact to each other because of the excess of internal rotation and adduction of the hip component. So it is not just the mechanism happening at the knee, it is the mechanism what is happening at the hip and the foot. It is the proximal and the distal joints which are concerned. So you can see Kajal jumping from the height, she may internally rotate and adduct and put the foot flat, unlike what Rupesh did. So there is no parallelity, there is no external rotation at the hip, the toes are not landing. So the knee valgus, what happens at the time of landing is called as cam. That is a knee abduction moment. Okay, the tibia goes out and the knee comes into valgus. It is called as cam, and that is found to be the predominant precursor of ACL injury, and that is one of the predominant modifiable factor for PFPS status. PFPS pain. Yes, Kajal, is it clear? Yeah.
Yes.
You just go to, there is one beautiful article in Joe's PT which talks more about the scam. You just go Joe's PT, you say PFPS and just write a female athletes. Yeah, female, I forgot the name, I'm sorry, getting older. So just write a cam female, you will find one beautiful picture. They would have given that cam. Okay, I forgot to put it on the slide. Actually, I should have done it. I think that is one important thing which is a precursor for ACL injury. Hina Dingra. And there was one question from Qureshi. Sir, how can we have a standardized protocol for different individuals as pain and conditions are different for everyone? Sir, okay, nice question. How can you standardize when you have individualization? That's what your question. Qureshi sir, can you unmute yourself and talk to me?
Hello, good evening, sir.
Yes, sir. Qureshi, please go ahead.
Yes, sir. So, as you told about standardization, I just wanted to know how can we standardize the specific protocol, because pain condition is different and different patients' body structure and everything is different. So, is it possible to standardize a specific program for a specific set of people?
Can you give an example?
Footballer will have different intensity.
Sorry?
Footballer will have different intensity of knee injury than fast bowlers or sprint runners.
Okay. Okay, you mean to say that you cannot standardize an exercise protocol because the demands are different? And why do you say that the possible research gap is standardization of exercise? Good. That was a wonderful question. I think you are a sports physio, right, Qureshi?
Yes, I am a student. Now I am in second year.
Second year, postgraduate, huh?
Yeah.
Okay. What is your specialization?
MPT Sports Physiotherapy, Annamalai
That's
University.
what I said, man. That's what I said. You are a sports physio. Good. Yeah.
Second year.
Yeah. See, when you are a sports physio, and now you say that you have to have an exercise for a football player. That may not be the same as good as the fast bowler. That cannot be suitable for a shuttle player. Good. But you can design an exercise for a footballer. In football, you can design an exercise for a goalie. You can design exercise for a forward. Okay. If you are going to teach an exercise for a volleyball player, you can teach an exercise. You can specify the program based on whether he is a smasher or he is a lifter. Okay, that is where a standardization really comes into play. How? See, for a goalie, he need not run for long distance. He has to cover. His agility has to be sharp. So it has to be more centralized and it has to be reflex based rather than a forward who has to run, who has to take the ball to distance, who needs to have agility, endurance, etc., etc. Yes, Qureshi, are you there?
Yes, sir.
So you can standardize in a sense to the specific sport, to a specific position, and you can outline the main core stuff. As I was trying to answer Kajal, when you are talking about a household lady, you need to standardize exercise for patellofemoral pain syndrome, but it depends on whether the lady is overactive or underactive. If she is underactive, motivate her. If she is overactive, put her little low so that the symptoms improves. Okay, so you have to see really standardize to the individual based on his position, based on the sport. So if you are doing your second year, which college are you in?
Annamalai University.
Annamalai University, good. After 10 years, if Qureshi comes up with a paper for a football forward, patellofemoral pain, you first have to identify, you have to collect all the people, and you have to see what are all the vulnerable factors. And based on the vulnerable factors, you try to intervene with the proper exercises, and you come with a standardized protocol that will be specific for the footballer, which I cannot put it to my Kandasamy and Muthusamy. That may not suit to him. Kandasamy and Muthusamy are a different breed altogether. But for you, for a football player, it is a different issue. So that's where the standardization comes. And it is an standardization which is individualized to the position, to the sport. Okay, standardization doesn't mean that one exercise for all.
It's according to the need of the individual.
Sorry, ma?
According to the need and the position of the player.
Yeah. You are right, and I'm also right. Okay, but it is something like that. It has to suit to the individual need, but you have to standardize. You have to standardize that particular exercise protocol for. See, it is quadriceps which you have to work on. That there is no doubt about it. But for a footballer, how you have to do it? For a swimmer, how you have to do it? What you have to concentrate? That is what the standardization is all about.
Okay, sir.
Okay.
Okay, thank you, sir.
Qureshi, did I answer your question? Or
yes, sir.
I've just tried to convince you?
Thank you very much.
Okay, dear. God bless you. Yeah.
Read the next question.
Sir, you said in Bharatanatyam, Aramandalam is a good posture. It is not Aramandalam, ma. It is Mabel Manoj. Boy or a girl? Should be boy. Okay.
Girl, sir.
Girl. What's her name?
Mabel.
You are Mabel?
Yes, sir.
Good, Mabel. Mabel, it is Aramandi. It is not Aramandalam. Mandalam is, you are from Kerala?
Yes, sir. Yeah.
Oh, good. I got it. Okay. It is Aramandi. Aramandi is half squat.
Yes, sir. I'm a classical dancer, but then
I'm sorry, I should not.
No. So, like in Kerala,
Yeah.
we are used to saying Aramandalam, so I just had that.
Okay. Sorry. Maybe in Kerala they call it as Aramandalam. It is called as Aramandi in Tamil. It's a good posture and will prevent knee injury. What about Murumandakam or full sit on toes? Can that cause knee injury? I'm sorry. What is it, ma?
So it's like I think it's called Murumandi in Tamil Nadu, but it's like full sit, but they're on toes, and there are like ballistic movements also on that.
Yeah,
so won't that cause injury?
Okay. That cannot cause you knee injury if you are going to properly practice on time, adequate intensity with adequate stretches. You are unlikely to have knee injury. Believe me, Bharatanatyam players and those sports people where they have slowness or they have control, they have less knee injury. Okay, knee injury is predominantly seen in football. It is seen in basketball. Okay, and I don't see much of knee injury in Bharatanatyam if it is being properly practiced.
Okay, so because most of the time we end up having knee pain, at least at the first day of practice, then we get used to it. So I just wanted to confirm.
No, see, this pain is not because of an injury, ma. It is because of a condition. You do something which you are not used to it, you definitely have this problem. Okay, suppose you happen to wash your clothes in a week. Okay, you wash your clothes for the whole of the week. One day you wash, you will have back pain. It is not the problem with your disc or with your spine. It is because of so many clothes in one day. If you start to wash every day, you will not have this back pain. It is something like that.
Okay.
So it is a question of conditioning. You had conditioning for the first year of the Bharatanatyam, after which you will not have pain. And if you stop it and you restart it, you will again get it. It is not a problem or it is not an injury. It is a question of conditioning.
Okay, sir. Thank you.
Yeah, thank you. So I'm getting a lot of Bharatanatyam questions.
Hello, sir.
Yes, sir.
So I have a question. Why in ACL deficit we are strengthening the quadriceps in closed position?
Sorry.
But
your name, sir. Your name, sir.
Vishnu.
What's your name?
Vishnu.
Oh, Vishnu again. Yeah, you tell me, Vishnu.
Okay. In ACL deficit, we are strengthening the quadriceps rather than popliteus hamstring muscles.
Okay.
The overactivity of quadriceps in knee extension, it will lead to anterior translation.
Okay.
Strengthening of quadriceps lead anterior translation of tibia. Why we are not strengthening the popliteus muscle and gastrocnemius muscle?
Okay.
Okay.
So what do you want to say?
He is asking why we are not strengthening popliteus.
Strengthening the popliteus and gastrocnemius.
See, that's what now. Let me make it very precise. I would love to talk for half an hour this topic. I was expecting this question as the first one, but you are asking the last one. Nevertheless, I would rather say, when we read our biomechanics, we were taught, don't work on quadriceps because it is an antagonist. In post ACL reconstructed knee, you work on strengthening of hamstrings, then you work on quadriceps. That was the way how we were taught. Now, see, my hair is white, Chandramohan hair is black. Chandramohan has been taught, don't just work on hamstrings, work on both hamstrings and quadriceps. And now you are younger than Chandramohan. Vishnu is now studying second year. In your book, it will be given as neuromuscular synergic pattern. It is not only quadriceps and hamstrings. It is your dorsiflexors, plantar flexors, hip flexors, extensors, adductors, abductors, internal and external rotators. Not only these, the core muscles, everything has to be strengthened as a whole. You cannot just work on one muscle and leave the other one. It is highly impractical just to select one group of muscles, say, I'm going to strengthen this, I'm not going to work on this. It is not scientific. You have to work on everything. You got it?
Yes.
Vishnu, there is one 5-mark question in PG. The difference between hamstrings and quadriceps in ACL. Okay, so they say quadriceps, when it contracts, it causes an anterior translation. Hamstrings, when it contracts, it causes posterior translation. Under what conditions? Under laboratory conditions. When you have a dead body lying, when you stimulate the hamstrings, the tibia translates posteriorly. When you contract the quadriceps, it causes the tibia to move anteriorly. So that was stated and that was written in the book, and that was what we read. So don't work on quadriceps, work on only on hamstrings. That was the way we were taught. But now it is being done on normal practicing individuals, where they have a co-contraction of both hamstrings and quadriceps, which maintains the position. And it is normally said as there is something called as shear strain, shear stress. When you work on quadriceps alone, you have excessive of shear stress and strain to patellofemoral and the tibiofemoral structures. When you have a co-activation and a co-contraction, there is a less amount of shear stress on the tibiofemoral component and the patellofemoral component. Okay, Vishnu?
Yes, he responded.
Yes, sir.
Yeah. So Vishnu, it is not just one muscle, it is a group of muscle. It is a synergistic activity. Depends on the purpose, depending upon the activity, and depending upon the goal, and it is universal. Head to toe it works. It is not quadriceps and hamstrings, believe me. Just try to evolve and come out of the concept, it is quadriceps or hamstrings. It is both. And not both, it is a concomitant work activity of the proximal and the distal structures, and the neural mechanism which comes into rescue. And core is very important. Core, I forgot to mention about that. I'm very sorry. Core is an important thing which maintains the complete body alignment and which can preserve your knee, both from knee, ACL, and from patellofemoral perspective.
Hello, sir. One more doubt, sir. In the quadriceps and hamstring are mobilizer muscle. It is for the mobility purpose. Okay,
sorry, Vishnu.
The quadriceps and hamstring muscles are only for the purpose of mobility, movement.
Okay.
Okay. There are deep muscles provide the stability of the joint. Okay. So strengthening of stability muscle rather than mobility muscle.
Okay.
Is important than mobilizer muscle. That's I am asking that the mobilizer stability muscle strengthening will give more result than strengthening of a mobilizer muscle.
മലയാളത്തിൽ പറഞ്ഞോളാം, മനസ്സിലായിട്ടില്ല ഇംഗ്ലീഷിൽ.
മൊബിലിറ്റി മസിലിനെ സ്ട്രെങ്തൻ ചെയ്യുന്നതിനേക്കാളും നല്ലതുപോലെ മൊബിലിറ്റി മസിലിനെ സ്റ്റെബിലിറ്റി മസിലിനെ സ്ട്രെങ്തൻ ചെയ്ത് കഴിഞ്ഞാൽ കുറച്ചുകൂടെ റിസൾട്ട് കിട്ടുമോന്ന്.
See, that was a good question. See, there is nothing like mobility muscle and a stability muscle. Every muscle is concerned with stability at one point of time, and in a different point of time, the stability, the muscle which was meant for stabilization, will be responsible for mobilization. So you have to first make sure your mobility is full, complete. Then you have to activate the muscle and put both mobility and the activity in stability, and this stabilization has to be tailored to a function. That's it. It is not mobility or it is not stability. See, it can be concurrent. It matters only in case of trunk, tonic and phasic muscles. Okay, in the knee, it is not going to be that way. It is going to be different. Okay, it has to be a co-contraction, co-activity, and you cannot definitely say mobility, so it should not be used for stability, and this is for stability, and which will give a better result. I don't think that makes really difference, and my knowledge is very little about that particular arena as concerned. As of I know, it can play an inter role, and I just feel that first you have to gain the mobility, then provide stability, then put it into function, and make them to play. Vishnu,
Okay, sir. Okay, sir.
Okay. Good question. Sir, my question is post ACL injury, patellofemoral pain is more prone. In the patellar tendon, oh, wow. Who's that? Priya Sonar. Priya Sonar, you are a sports physio?
No, sir. Hello, sir.
Yeah.
I'm a student. I'm a VPT student, actually.
Oh, good. How did you ask this question? I'm astonished.
A few days back, I just had a webinar from the same ExRxIndia organization on ACL rehab, post-op ACL rehab, and I just learned about this graft, and I had this question in my mind, just a student question, actually.
Good. I think you have got a good observation skills. Very good. Which college you are from?
Thank you, sir.
Sorry?
Yes, sir.
Which college you are from?
Which college?
Acha, I'm from NIMS University, Jaipur, Rajasthan.
Jaipur. Wonderful, Priya. You have got good observation skills. To answer very specific, the patellar tendon graft has got more vulnerability because there is something called as, no, sorry, I don't want to take much of time. Let me answer your question. In case you take the graft from the patellar tendon, you have more vulnerability of you to have joint issues as far as patellofemoral pain is concerned, because it has got a reflex inhibition of quadriceps mechanism, and it can cause a lot of wastings and a loss of muscle volume, physiological cross-section area, where which it has got the muscle tension properties to be lost, and it has got a direct effect on the patellofemoral articulation, and the kinematics is highly altered, and it is more prone for patellofemoral. That is why like we stress more importance on patellar mobilization following ACL reconstruction. We try to highlight the importance of patellar mobilization. Immediate post-op, we teach to the patients all the medial lateral glide, superior inferior glide to be maintained, to be retained by the individual at all the times, irrespective of whether he is doing actively. At least you have to passively mobilize. And the best thing what you have to concentrate on is the superior translation, that is superior mobilization of patella has to be highlighted. So that is where you maintain the flexibility of the ligamentum patellae. So you try to preserve the flexibility, and the collagen tissues physiological properties are maintained so that you have less vulnerability of reflex inhibition patterns. Yes, Priya Sonar, have I answered your question?
Yes,
hamstring graft has got the lesser vulnerability, and patellar tendon graft has got a higher, it's more prone for patellofemoral pain. Yes.
Yes, sir. Thank you, sir.
Yeah. And now, did I answer your question, or still you have some question?
No, sir. I got my answer.
Yeah, it is more in patellar tendon because it directly affects the patellofemoral physiology. I'm sorry, the quadriceps physiology. Okay.
Yes, sir. But we still consider patellar tendon graft more in patients related to sports because it's more stronger and it causes bone-to-bone healing. Although having this issue.
Priya, are you really a student?
Yes, sir. I'm a second year BPT student.
You're a postgraduate?
I'm a second year physiotherapy student, BPT student.
I'm astonished. Good student. Excellent. Yeah. Yeah. I'm sorry, Chandramohan, I'm taking a little time. Can I?
No problem, sir. This is for them. This webinar is for them.
Tendon, as you rightly mentioned.
I really astonished because she was asking questions from others session, and she says that she is from second year BPT.
I really doubt it. I need to talk to Jaipur people and get it. Priya Sonar. I'll find out. Okay, see, Priya, what happens is, as you rightly mentioned, patellofemoral, in ACL deficient knee, especially for sports population, the most preferred graft is the patellar tendon graft,
Yes,
which we call it as BTB graft.
yes,
As you rightly mentioned, it is a bone-to-bone healing is better, and because of which you have a better function, and we have got a better stability in place, and the recovery rate is a little slower when compared to hamstrings. Hamstring tendon, they recover a little faster, but the lasting effect is patellar tendon is much more better when compared. But it is still in dispute. But it is the most preferred choice of graft is BTB graft, and most surgeons will find it comfortable to put the bone-to-bone union better than a soft tissue which is being preserved further. As you rightly mentioned, it is predominantly the BTB which is of graft of choice. But despite of the patellofemoral pain syndrome incidence, BTB is the preferred choice. But as a physio, your role becomes critical. If the surgeon selects the BTB graft, despite the vulnerability, it is up to you to preserve it, maintain the contractility, maintain the flexibility, maintain the mobility of patella, and avoid PFPS. That's where Priya Sonar comes into scenario and help the orthopedic surgeon. Yes, Priya?
Yes, sir, I got my answer.
One more question from you.
Yes, sir.
Any other questions from you?
No, sir, I've got my answers. Thank you, sir.
Patellar tendon graft is the most preferred choice, and of late research has shown, I think there are some few articles which have done 10, 20, 30 years follow-up. They show a good outcome with the patellar tendon graft, but I think they're still in dispute. But nevertheless, physiotherapist role becomes critical and crucial and very important when patellar tendon graft is the choice and vulnerability is there. Therapist role becomes important.
Yes, sir.
Yeah, Hina Dhingra. Can you explain hamstring quadriceps ratio? Good. Who is this Hina Dhingra? Okay, Hina, you're a student. I just consider her a student and just say that there is something called as quadriceps hamstring ratio. Quadriceps muscles are considered to be double the time stronger than hamstrings. Okay, so quadriceps being an anti-gravity muscles, it has got 3 or 4 components. The most important is your vastus medialis, and the strength of quadriceps is considered to be stronger than hamstrings. They are a little stronger than hamstrings in a ratio of 2:1. That is the normal ratio. And of course, papers and studies shows this may vary from individual to individual and site to site, but predominantly we see 2:1 is the normal ratio. And when it comes post-injury, we just think of 1:2. That is, for example, normally when you have a stronger quadriceps and a weaker hamstrings, when you have an injury, you try to put that opposite. We had a school of thought where we say hamstring is to quadriceps, you have to work for 2:1 ratio. It's impractical, but we were working in earlier times. But now it is not the ratio which matters, but normal ratio of quadriceps and hamstring strength is quadriceps is stronger and hamstrings are weaker compared to quadriceps. And the ratio is 2:1. That's a normal thing which we find. And some places it is 3:2, not exactly 2:1. It varies from place to place, but of course the research is still on. Good, maybe you can work on that. Hina Dhingra can work on quadriceps ratio.
Okay, sir. No more questions, sir. We will finish.
Thank you, sir.
Thank you. Let us all unmute, and I have a question for everyone.
Yes, sir.
Okay, sir.
Coordinator, please unmute all.
Yes, sir.
Please, please unmute everyone.
Yeah, unmuted, sir.
Yeah. Out of this 95, can I expect 3 papers in the year 2021?
Yes, sir. We will work on, sir.
Sure, sir.
Yeah, Professor
You
Vincent
have
is saying
taken
yes.
a topic, we will work on it. Rupesh is there. He is having data. You already noted a topic.
Yeah, Rupesh is already on.
Rupesh.
Yeah.
He is having data. We will work on it. And now Vincent there has.
Yeah. So I wish this opportunity should definitely, we should come out with at least 2 papers in the year 2021.
Yes, sir. Yes, sir. I always
That is my
have an eye
request to
on
all.
hamstring knee reflex, sir.
Yeah. Good. Already we spoke last time, na?
Yes, sir.
Yeah. Hamstring reflex.
Bhushan is
God
also
bless
saying he's working with. Bhushan, are you working with the shooting team?
Yes, sir. I'm working with shooting team right now.
So you are Manoj's friend, na?
I'm Manoj's student, actually.
Okay.
I was working with him also, and in his clinic, Mudra Clinic. And right now, I am with shooting team.
Good. I think we should come up with a paper. The ultimate aim of this paper's webinar should be that you should have a good scientific part, and you should all come out with a paper and not just attending a webinar just like any other thing. Thank you. Thanks all.
Yes, sir. You will have some papers, sir.
Thank you.
Even Revati is saying yes, and I think we will get 4 or 5 topics.
Yeah, thank you. Thanks all.
Thank you, participants. Thank you for your patience. It's a very lengthy session. I think this is the lengthiest session we ever had.
Hey, I finished on time.
For the lengthiest session, it is more interactive session, sir.
More interactive session, yes.
I did finish on time.
Yes, sir. You finished on time, but the question session took another 45 minutes or so, sir.
Yeah, I'm sorry for that.
Good. No, sir. It's really interesting.
And I thank all the participants from India and abroad also. And I thank our sir, Mohanakrishnan sir, for patiently answering all the questions. And I thank ExRxIndia team, Dr. Rupesh and Professor Tuna Saha. And I thank our Professor Vincent Jairaj to stay till the end. And yeah. And thank you all. Bye, sir. Good night. Bye, all.
Good night. Thank you, sir. Thank you so much.
Thank you, sir.
Thank you. Bye.